It's super easy to get lost in the weeds about pulmonary hypertension, so today I'm going to tell you about the things you need to know for step 1 and step 2. In case we haven't met, my name is Timothy Dillinger. I'm a 4th year applying anesthesiology, so let's get down to it. Let's quickly go over some definitions. Pulmonary hypertension is, by definition, mean pulmonary arterial pressure greater than or equal to 20 millimeters of mercury at rest. This is diagnosed on right heart cath, which will get these measurements. We'll talk about that later. Precapillary pulmonary hypertension is a pulmonary arterial wedge pressure less than or equal to 15 millimeters of mercury. Post-capillary pulmonary hypertension is the same thing but greater than 15. Cor pulmonale is when the increased pulmonary vascular resistance causes right ventricular hypertrophy, which causes right ventricular failure. I think of this as the lung problem causes a heart problem. There's 5 major groups of pulmonary hypertension. Group 1 is pulmonary arterial hypertension. This is the idiopathic version, or it's hereditary. There's a couple other causes, but the main thing you need to know for this is that it's pre-capillary. Group 2 is left heart disease causing pulmonary hypertension. I think of this as a backflow problem. You have HFpEF or HFrEF, or you have valvular disease. These will be post-capillary. This is the most common cause of pulmonary hypertension. If you get pre-capillary versus post-capillary confused, just know that it's really looking at where is there increased pressures. And so if it's pre-capillary, it's really going to be caused by the lungs themselves. If it's post-capillary, it's meaning that there's pressure that is after the lungs, which in the vascular system is going to be the left side of the heart. Group 3 is lung disease or chronic hypoxia. This is going to be COPD, interstitial lung disease, or OSA. Group 4 is chronic thromboembolic pulmonary hypertension, or CTEPH or CTEPH. This is caused by chronic PEs. And lastly, group 5 is multifactorial or an unclear cause. So this would be sarcoidosis, hematologic causes, sickle cell disease, and metabolic disease. Depending on the group, you have different pathophysiology, and so I think of 2 major pathways. So the first pathway is endothelial dysfunction. This is decreased nitric oxide and prostacyclin, or an increased endothelin 1, which would be the hereditary version. The other pathway I think of is chronic hypoxia. In response to chronic hypoxia, the lungs are going to cause vasoconstriction to divert blood flow to areas that are well aerated. And so when you have chronic hypoxia, you have multiple areas that are not getting blood flow, which they're squeezing down, and that in totality will cause vasoconstriction. I think of this pathway mostly for group 3, which is going to be chronic hypoxia like COPD or interstitial lung disease, causing massive vasoconstriction of both lungs. The clinical features are mostly going to be exertional dyspnea, though you can also get syncope, you can get fatigue, and then you can get angina if you have the right ventricle remodeling causing so much hypertrophy that you actually have ischemia due to demand. Some signs that you can see on exam would be a loud P2, or you can also see a right ventricular heave, as well as a couple other things listed. For diagnostics, you initially want to do an echocardiogram. This can estimate the PA pressures as well as look for right ventricular strain, but really the gold standard test is going to be a right heart cath. You can also do a VQ scan if you're concerned about CTEPH, that's group 4, and that's going to show chronic PE. A chest x-ray and an EKG may be given, which may show signs of right ventricular hypertrophy, but those are non-specific. One key highlight is that you should never diagnose pulmonary hypertension based on an echocardiogram alone. You should always confirm with the right heart cath. Here's a couple of buzzwords that you may see on pulmonary hypertension on step 1 and step 2, but they're pretty buzzy, and so I'd really focus on the rest of it because that's more fundamental. This video covers about 80 to 90% of the stuff you need to know for pulmonary hypertension, so hopefully this is helpful to really focus on the high yield stuff before your exams. I know that you're going to crush whatever exam you have coming up. Let me know in the comments if you have other topics that you think would be helpful for you. Otherwise, I'll see you in the next video.